Hi everyone, welcome to the last video on the lungs. So I'm going to go ahead and share my screen here. Um, where's lungs? There we go. There we go. Okay, and let me just get this particular thing playing. There. Okay, so welcome to the lungs. There we go. So our lungs are actually considered a primary functory. They're not quite like the liver or the kidney, where you have that Batman and Robin relationship of metabolizing by the liver and then filtering with the kidney. The lungs actually kind of also have a dual thing going on in the sense that they're also a site of exposure. I mean, obviously, the lungs are a site of exposure. The liver is a site of exposure in that you eat food, your body absorbs the toxins, the portal circulation brings it to the liver. But the lungs are very much a direct source of exposure when it comes to toxins. Their main function for elimination is to deal with blood acids, so gaseous wastes as well, weak acids and carbon dioxide all come out through the lungs. They also eliminate colloidal waste, so like gluey things in the form of like mucus, glares. So your conditions like asthma, bronchitis, sanity, rhinitis, all those things where you're dumping from the respiratory tract, those are all things eliminated by the lungs. The interesting thing is that in cases of cancer, and when cancer is dying off, there's necrotic material to excrete. The lungs is also another place that you'll see more mucus and glares eliminating things. So sometimes when we're eliminating, it's not always a bad thing. It's actually the body's strategy to get things out. But the reality is that for in some cases clinically, like, is there maybe a better strategy? Do we want to do it that way? What is actually causing us to actually want to get things out that way? We have to ask deeper questions. So one of the things about the lungs is that if you're actually finding a lot of serious congestion around the lungs, you probably have somebody who's in a lot of trouble. You might have like congestive heart failure, pneumonias, like there's all sorts of things here that you will notice. I do even find in a lot of pneumonias when people are breathing, I can, how we've been taught to listen with stethoscopes. If it's really bad, I can feel it and hear it through my hands, so to speak, any disturbances like that in the lungs. And they're also very much involved in lymphatic and venous circulation. They're very closely associated to the heart. We know that the heart pumps the unoxygenated blood into the lungs, and then the lungs send it back to the left side of the heart, and then it's pumped to the rest of the body. So they're very much involved in the thoracic duct dumping into the venous circulation and then having that lymph move into the blood and work through the lungs as well. So they have a pretty significant role to play in the body and are very important organs. One of the things we want to think about when we're working with them is that we want them to be able to expand really well. The thoracic cage can be a little bit constricting for them. So coming back to understanding the three-dimensional nature of the body and that we actually really need space in there so that things can expand really well. We also want them to be able to glide really well. The lungs are, of course, enveloped in pleura, and there's two layers to that, the parietal and the visceral layer. And we really need those layers to be able to glide. There's a serous fluid there, so we need that hydration of the tissues as well. So the thorax, let's talk a little bit about the cage first. Of course, it's there to protect those vital organs. It's on one hand got a bit of rigidity to it, but it also needs to have flexibility. It needs to have mobility. There's a ton of micro movements that happen with the thorax. There's a lot of articulations here. And that quality is really what it allows it to absorb shock. So it kind of reminds me of bone in the sense that even in bone, we want to see a rigidity to that bone, but also an elasticity to that bone. So it's the same with the thorax. We don't want it to be rock hard and not able to expand and absorb shock very well. We want a pliability to the whole thorax and not just like a part of it. So one of the things to remember is that the general axis of the thorax actually passes a little bit anterior to the heart and the ascending aorta. These structures are a little anterior and to the left. And when we look at the thorax, we as chiropractors probably overemphasize the vertebral articulations. Not saying they're important, also with other people who work manually with the body, but we actually need to step up our awareness into the three-dimensional nature of the body and be conscientious of the contents, not just the container, and that these structures have relationships to each other, and we need to understand the dynamic of those relationships because that will really help us identify where things need to change in order to improve the thoracic dynamics. So one thing to remember is that bony articulations, they're important. There's 150 of them that move with respiration. That's actually really quite a large number when you think about this. You can have a small restriction disturb this whole complex mechanism, making it harder to work. This will happen without actually having any signs or symptoms. We see that all the time. We see people with problems with mobility in these articulations all the time as chiropractors. It doesn't necessarily mean those people have symptoms there. But what we do see is that after a while, the body, after years and years and years and years, is just suddenly sometimes not able to compensate for these anymore. And then we start seeing the symptoms arise. And so, or even problems in this area. And so I think on one hand, there's a bit of a fatigue that the body has with dealing with restrictions, but then also too, just layers upon layers of more and more restrictions. And then suddenly we have some problems that are actually speaking to us in the form of symptoms. So we have to think of the thorax as having a soft and a visceral frame. So the soft tissues of the thorax create a frame and it's supported by that hard frame of the bones. Then we also have the organs in the thorax, which have a shape as well and a frame. The lungs, of course, are an organ that it expands and contracts quite a bit. I wouldn't necessarily call it being an organ that has like this huge like an actual heart, like a frame that seems to give it shape. If you left the lungs uninflated, they're just they're not the same. They don't take up the same space that they do when they're inflated. If you've ever played with lungs ever before in a dissection situation, both of these organs, the heart and the lungs, they move with very large amplitudes and very regularly. They never stop and we don't want them to stop. So they're both very highly mobile tissues and organs. And so they also have their own suspensory systems. So when that suspensory system is affected, et cetera, it can actually eventually result in serious pathology. It's a lot of work sometimes for these organs to work against some of these dynamics where they're actually under some mechanical strain. So basically, just don't forget that just like the liver and the kidneys, these organs are surrounded by a fascial system. And on one hand, that fascial system suspends it, protects it, but it also allows it to be mobile. So origins of thoracic restrictions. Now, these are probably not news to most of you, but of course, mechanical trauma, whiplash, all those things can really affect the thorax. We see infections have a big impact on the thorax. It's probably a more common infection that we could see as maybe something like pneumonia or a history of pneumonia that can really change the slide and glide of that particular lung because of that history of inflammation there, and the tissues lose that ability to slide and glide on each other. So you might find restrictions there. Tumors and problems related to tumors, maybe even having surgery, those can create something that the body has to work around because those tissues will have a different density and relationship to the tissues. They're usually not functioning well with the rest of the tissue around them. We're going to see obstetric issues affect the thorax. So, of course, the position of the child in the womb and how the womb is presenting and how we're adapting to that womb can actually really affect the thoracic inlet and also the hiatus at the diaphragm. Of course, surgical history of surgery can affect tension in the thorax as well, and that can be extra thoracic. That doesn't necessarily have to be a surgery that's happened in the thorax specifically. Of course, pollution, this is one of our sources of exposure. This is something that our lungs will be breathing in and having to somehow process, and actually either will absorb that pollution or will try to shuffle it out through the cilia and the mucus that we excrete. And of course, we can also have things like an autoimmune disease like sarcoidosis, I have seen cases of sarcoidosis, and you get definitely spots where things are not moving very well, and it can make it hard for them to breathe. I definitely see that slide and glide that should be there decrease in just discrete spots with a condition like sarcoidosis. COPD can be quite challenging because we really are losing that integrity of the lung tissue with that, and that can present in different ways. We do see changes to the thorax in COPD, etc. So just something to be mindful of when you're working with the thorax. Also, when we consider the Addison's-Wright test, as we test that the pulse here at the wrist, for some reason the name of that artery is blanking on me, but when we do that test, we're going to see a decrease in arterial circulation. But if arterial circulation is decreased, then we also have an effect on the venous drainage as well, because artery is always high pressure. So it's going to work really hard to get blood to where it's going, but the venous is not high pressure, so it's more impacted by compression. And so we're going to talk a little bit about this test specifically and when to consider a more mechanical thoracic container type restriction versus a visceral one. And so we'll get to that in one of the later slides. So when we're considering the thorax, one of the things that comes up is that disease in this area can be quite serious, or any problems. So say if somebody's actually having a heart problem and not a thorax container problem, there are a few things that can help us differentiate that. A lot of times when something is mechanical, it's pretty consistent and it doesn't change fast. Oftentimes rest will help us. It's not often something that will wake us at night, like between 2 and 3 a.m. We're not necessarily going to have, if there's an infection, like we're not going to see a fever or swollen lymph nodes, et cetera, with it as well when it's mechanical. I think another thing to remember, and this is kind of tricky because anxiety can play a role here, is that when there's actually a problem with an organ, you're going to see a lot more autonomic dysfunction. You're going to see more like a sense of fatigue, sweating, nausea, agitation, and just a feeling of not being very well. And maybe there isn't really a great way to describe that, because that the dysautonomia that somebody might be experiencing is sometimes something that's hard to put your finger on in terms of symptoms, but you just know you don't feel right. A lot of times too, with mechanical pain, things feel very well localized. You might have a short-lived radiation of that pain with sneezing or physical effort, but then once that's done, it's better again. So these are just things to consider when you're trying to make sure that people are in the right place, that they should be in your office and not somewhere else. And so this is a nice little visual about the lungs. Of course, on one hand, I love looking at these nice, beautiful, healthy pink lungs with a nice, healthy heart nested in there. And you can see, I feel like you're missing one of the fissures that you should see on the left side, but that's okay. And then you look over onto the right side of this picture, and this is obviously the lungs of a smoker. You can see that there's a lot of fraying, almost it seems like, of the tissues at the fissures. And of course, the lungs are blacker from having the output of the cigarette smoke in the lungs. The other thing I really like about this picture in terms of looking at the heart is that you can see a little bit more of fat invested around the heart. So again, when fat deposits in the within the visceral cavities, it likes to deposit in these suspensory elements. So we will actually see, the fat in some of these between those layers of pleura and pericardium and things like that. And I find in the thorax, you're going to see it more around the heart than you will the lungs, but just to be aware of that's where the extra fat is going to be deposited. You can also see that this heart on the right side is also somewhat enlarged. It would be heavier on the liver, so this would actually cause a little more stress on the liver. So just a great visual to kind of recap some of the things we've been talking about through these videos. Topographical anatomy of the lungs. These, of course, are pictures from Netter, and I just really, really like them. For starters, on the left side, you can see the fissures of the left lung. So the left lung, if you remember your anatomy, has two lobes. And so you can see that fissure slicing down on a diagonal on that left side. And you can see where they've cut the pleura away and how the pleura drapes over the diaphragm quite a bit, quite significantly. And then you can see in behind that, the heart is still covered by the pericardium. And then on the right side, you can see the superior lobe, the middle lobe, just underneath it, and then part of that inferior lobe just at the lateral border there. You can see the fissure for that. So we're going to talk a little bit about fissures because this is a place that you can actually also find issues with the slide and glide. There should be some mobility in those fissures. Those lobes should be able to move nicely on each other as people breathe, and that can be disrupted by things that we talked about, trauma or infection, etc. On the right side here, we have just a little bit simplified picture of the lungs. You can see the pink tissue through the body there, but then you can really nicely see that pleural drape. You can see how that pleura even comes down and covers the superior pools of the kidney. And so just to be aware of the fact that although there's no lung tissue, the pleura come down that far, and that becomes really fascially important and something to be paying attention to. The thoracic outlet. So really can't cover the thorax without the thoracic outlet. And it's a tiny space. This is actually a very small area, and we're going from a very narrow neck to a very broad thorax. So we're changing dynamics quite a bit here. And so, of course, there's a lot of structures coming in and out of here because a lot of the communication between the brain and the body is going right through this area. And so, of course, we've got vascular structures. So we've got, the subclavian artery, etc., in this zone. We've got neurological structures, everything from like the stellate ganglion and vagus nerve, phrenic nerve, brachial plexus. There's a lot of nerve stuff going on. We've also got muscular structures that are happening here. You've got your scalenes and your SEMs and all of those kinds of things. And even the posterior cervicals are bordering this area, and subclavius, etc., just underneath. So there's a lot of muscles that can be playing a role in the dynamics at the thoracic outlet. It's also a very important area for lymph drainage. It's very rich with lymph nodes in this area and lymph vessels. So there's a lot going on here. So we've got also I guess we can't forget also too that we have the spine and the spinal cord within the spine and all those nerve roots as well. So when we're looking at the thoracic outlet, a really simple test is the combination of Addison and Wright test. And yes, the radial pulse. So you would check the radial pulse in your person in a seated position, and then you're going to slowly externally rotate the arm. And then once you've gotten as far as is comfortable, then you're going to slowly abduct the arm while listening for the pulse. And so the pulse in an air when the thoracic outlet is really open and free and everything's feeling really good in there, you shouldn't lose the pulse as you move through range of motion. And so when the the radial pulse like actually diminishes, we know that then the subclavian artery is becoming compressed. So this is just a witness to everything else that might be happening in that area. And so when the pulse diminishes within the first 30 degrees of external rotation, we know that, like, right off the bat, right in the first part of the movement, we've got probably a mechanical issue in the thoracic outlet. If it's positive, if you start to lose the pulse and it diminishes between 30 and 90 degrees in the adduction, then it's a visceral restriction. And then if it only diminishes once you get to the top and you turn their head, you know that it's probably more likely an osteoarticular restriction in the upper thorax or lower cervicals. And again, this is also just helping you identify where the potential is the greatest, but it's also something that you can assess as a pre and a post outcome measure, or if it correlates with symptoms. I had someone recently who was complaining of their arms going numb at night and that waking them up. And sure enough, their Addison Wright test diminished when they got to about 80 degrees of abduction. And then it was interesting because post-adjustment, we were able to clear that up and it was fine. And there was no more diminishment in the pulse. And then they reported that their symptoms of having their hands go numb at night actually cleared right up. So, this is a really important assessment for the thoracic outlet. And because we also know we don't necessarily want to chase symptoms. We want to actually understand the underlying dynamics of what's going on and help open up that body in a three-dimensional way so that everything just works better. But it's a nice little tool for assessing where you're at in that process. So here we have the pleural dome. And so that's this area up here in our clavicular triangle. And the one thing that's, again, really important here is we have a lot of different names for the tissues that all interconnect to hold everything together. But really, it's one big tissue. It doesn't really end and become something else when we start talking about it. But of course, we've got fibers that connect to the trachea and to the esophagus, to the arteries, like the vertebral artery and the subclavian artery. We have pleural vertebral ligaments. So the dome of the lung actually attaches to the vertebra. We're going to go over a set of ligaments that attach to the vertebra, the TVP and the rib in one of the next slides. We also see that it really invests actually the stellate ganglion. And we also have our first thoracic nerve bumping out there, et cetera, and a connection to the scalenus minimus muscle, the first rib, et cetera. So this is actually considered the suspensory apparatus of the pleura. And I always find it really interesting when we consider what we are teaching in BGI. And for Sue, the logic of BGI came out of what she noticed clinically, and she started to notice that she had to go in and she would find stored potential in the clavicles that actually needed to be addressed with the posterior. And I find it really, really interesting that this makes actually a lot of sense when you consider the fact that the lungs actually provide a negative pressure that suck up the liver and all the other organs in the abdomen and pelvis and actually provide a bit of a support in terms of having that negative pressure when the other cavities are positive. And, the most superior aspect of that organ support is right here in the thoracic outlet. And lo and behold, that is also an area that we needed to include in our posterior geometry in terms of helping resolve the tensions that were being held in the posterior geometry. So just a fun fact that, it's really nice when somebody's clinical experience helps them hunt a little bit differently, because she would find that maybe she wasn't getting the results that she wanted. So she started exploring a little bit more, and that it led her to this zone, which she called the clavicular triangle. And it totally makes sense in terms of just the mechanical dynamics of the body as well, that the spine and the back are these, foundational structural supports for the body, but then this is where pretty much all of your organ systems from thorax and down are being suspended. So there's a structure called the suspensory ligament of the pleural dome. It's actually broken up into three pieces. So it really is just a continuation of that fascia that is the pleural dome. And so you've got the pleural vertebral that attaches to the vertebral body of T1 there that you can see. And then you've got costopleural, so you can see it attaching to rib 1 to be suspended. And then we also have the transverse pleural fiber as well, going to the TVP of C7. So, this is a connective tissue bridge to the bony structures there, but there's also some connection to muscular fibers like the scalenus minimus, and the medial scalene muscle as well, the median scalene muscle. And so, this doesn't actually directly insert into the pleura. It's like there's a layer they call the intrathoracic fascia, and then that connects to the parietal pleura. But this is basically the main suspensory elements for the lungs. So another really fun structure is the lung ligament and the interpleural ligament. Sorry, guys. And so it's basically the lung ligament is, if you can imagine, you've got the pleura wrapping around the lungs. And then as it comes into the mediastinum, those folds come together at the hilum, and then that actually goes down to the diaphragm and it connects to the esophagus as well. So it's kind of that mediastinal connection. And so all of the mediastinal structures are actually invested in all of this. And so the interpleural ligament is also considered to be like a link between the two lungs. And so you have lungs on each side, but there's actually this fascial connection that happens if you look over onto the right side of this picture, that connects the lungs on either side, but it goes just in front of the vertebra and the aorta. And actually you can see the esophagus there as well, so connecting with that esophagus as well. So again, we have another situation where we very much, just like the kidneys, can work with these structures as paired structures and know that they're connected. But we also know that when one side is definitely impacted by some sort of tension, either from itself and how it's articulating within everything, or some other tension that might be affecting it, it takes the other one with it a little bit. So a lot of times we'll see improvement on the side that we haven't worked with when one side actually improves quite a bit. So respiration in the lungs. So we want to just look at mobility of the lungs essentially. And so of course, when the lungs, when you inhale and they expand, we're going to see them move down. When we exhale, we're going to see them move back up. If we have a very deep forced inhalation, we're going to see that move even more. When we have a very deep forced exhalation, we're going to see a stronger and longer move up as well. And so, respiration, when we palpate that, actually gives us a lot of information about how the thorax and the lungs are working. You can get so much information from respiration. I love using movement for assessment. Static assessment is always really great, but just some of the natural movements that the body does tells you a lot about what might be happening in the structures under your hands in terms of their dynamics and where they're storing a lot of tension. And, it just helps you figure out what you might want to prioritize as a kind of a clinical goal with your work. So motility of the lungs. So this is not mobility, like what we're looking at with respiration. Motility of the lungs is, again, that very subtle motion that we see in the lungs, kind of like the cranial sacral rhythm. It's very slow, 7 to 8 cycles per minute. So careful not to be distracted by the respiratory rhythm. So it is a different rhythm than respiration. So that can be a little bit tricky. So a lot of times when I'm assessing motility of the lungs, I don't ask people to hold their breath, but I ask them to just try not to like breathe super deeply or anything like that. And so because it can be distracting. But as you can see, really we have a nice rotation that's going to happen with the lungs. And as you go further down in the lungs, that angle is going to change. And again, this reminds me a lot of the coronal motion, which we'll talk about, because we know at the top in coronal land is that we're at the base, and there's not a lot of excursion movement in the arc of movement with the coronals at the bases, but much more at the apices, which is where the bottom of the lungs would be. So we see more movement there. So here we have a picture of the superior costal coronal plane, and you can see up top near the very top of the lungs, that's our base. And then as we come down where the diaphragm would be, there's a lot more motion. There's a larger arc of motion there. So yeah, so here we go. So one of the things that you can do is you can place your hands in these kinds of positions, and we can check. Of course, in this picture, they're looking at oblique fissures, but we can check and see, are we getting the kind of motion that we want to see in this particular area, and is it at the right angle? There we go. So one of the exercises that you can start working with is just assessing mobility and motility of the lungs in people in your practice before we get together in May at the castle, and just try to work with that and see what you find. This is another lovely mobility test that you can use. I think actually if you were wanting to try and find somebody who had a very good example of restricted mobility, you might pick somebody who maybe has had a history of pneumonia and is maybe also just feeling like, breath is just hard since then. And in this case, you can lay them down and create a dynamic of a stretch between the thoracic outlet and the pleural recesses. So you want to also side bend and rotate the head to stretch to the opposite side so that you're going to stretch those cervical pleural ligaments. And then your hand is going to come onto the costodiaphragmatic recess, so where that pleura drapes, and you're going to actually try and push that inferior, so inferior and medial while people inhale. And when you're doing that, if the person can't easily inhale, it's a sign that there's a lot of tension in the pleura. So that can be a really great way to just test for tension in the pleura. I find I can generally feel it just by checking respiration. I don't spend a lot of time doing these tests, but doing a bit of this on a few different people and then translating that to what you notice when you have them breathe can be a really useful exercise, because really, actually, if you just check and palpate while they're breathing, I feel like this is a test that you should almost be able to predict if you've done a good job of listening with your hands in terms of for any restrictions while they're actually inhaling and exhaling. So, of course, things to consider about the lungs. Of course, trauma affects both the container and the contents of the lungs. So you want to consider traumatic events that they've maybe had in their history. And you want to also remember that the suspensory system of the liver can really affect the diaphragm and therefore the lungs. Also, too, the thoracic outlet can be an area where there's a great deal of tension, from that trauma, and affect the suspensory ligaments of the pleural dome, etc., and all of the structures contained in that outlet. I mean, we often see that with whiplash, that there's quite a bit of stress on the structures at the thoracic outlet. The other thing is here, I find toxins have a little bit of a different feel. So the lungs are definitely trying to relieve the body of toxins, but I also find that it's a site of exposure and absorption. And hopefully, I find in my practice, because I'm generally dealing with people who want to be healthier and stuff, I'm not really seeing the lungs always feeling like a place that's getting overburdened with toxins, and they're just not, we're just seeing way too much mucus and junk coming out of the lungs because it can't get out the other ways. So that's one of the things to think about. If things are coming out of the lungs and they really shouldn't, think about the fact that, okay, we need to facilitate the other ways that things should be able to get out through the liver and kidneys. And always think of that as kind of, you want toxins to go out the right way. When they start showing up in other areas of the body, like the skin, etc., that's the wrong way most of the time. There are toxins that leave, of course, through every cell of the body, but when they're actually starting to express some sort of itis, inflammation, etc., then we know that we're not actually keeping up in those primary emunctories, that they have more of a load than they can deal with. So again, when we're dealing with the thorax, just try to remember we want to look for where the potential feels like the greatest. Is that tension expressing in the geometry of the thorax? Is that potential somewhere else? Things can be outside of the thorax, but having a big impact in the thorax. So don't be afraid to let your palpation lead you to other areas and see where you land with your hands. So the distortion of the thorax. You know, there can be, in some cases, and I can't say I've seen this very much, big deviations in the mediastinum, and that can create a lot of problems. It has been known to laterally deviate or vertically retract. That's very serious. I can't say I've seen a lot of this at all. If your thoracic mobility and motility are not normal, there's osteoarticular issues, etc. You're going to see these in like the ribs, the vertebra, the sternum, the costal cartilage. Like that is just going to be in absolutely every tissue. And so that's where having a global approach like BGI, where we're not zeroing in necessarily on just one tissue, we can look at how it's all functioning as a whole and how that tension is actually layering on all of these structures. It can be really useful for actually restoring the thorax and helping it actually disentangle from all of that distortion that it might be experiencing. The other thing I wanted to talk about is, of course, our CT junction. I think it's Danielle Mutt who calls it like the confluence of tension and the confluence of the geometry here. So we've got a lot of different types of geometry coming into here. We've got bases and apices, so it's not one thing. And so I really feel like that CT junction is just a powerful witness to distortions in the geometry of the body everywhere. All of the foundational geometries, even I find the internal geometry, have a really big impact on this area. And so there's, at the end of the day, one thing to consider is that the venous circulation is often the first thing to be compromised because it's a low pressure system. So just consider that in terms of what you're seeing. I just thought I'd throw a few pictures of geometry in here. You can see the clavicular triangle. You can see the sternal triangle, facial triangle, abdominal triangle in these pictures here. But you also have the posterior triangle of the thorax where the apice is at the top at C7. So there we go. There's just a lot of stuff going on in here in terms of the geometry, and you can have a lot of things layering up and having an impact on this area. And there we go. We have our picture. So one of the things, we will do this hands-on, but this is actually, for this to really land in your head, you might need to repeat it quite a few times. But the lung fissures are really important. Again, where we want to still see some give and some slide and glide, we don't want to see these stuck on each other. So if we consider the left side, if we have somebody laying on their right side, so their left thorax is available to us to palpate, we can move their arm out of the way and get on their sides. And really, if we put our superior palm on the posterior aspect of rib 5 and the other on the anterior aspect of rib 6, we can, apply a little bit of a pressure to just try and get down into the depth of the pleura and the fissures, and we can just test that. We can also take the time to listen to respiration in this area when people breathe. Is there a nice even movement? Is there a little hiccup in the movement in terms of drawing us into that fissure as well? So this is actually really important to know this. And then also, if we look at the picture here on the right side, the inferior lobe is labeled number 1. So we see a lateral aspect here. And notice the inferior lobe sometimes is higher than the middle lobe. I know that. I didn't make this stuff up. So, and then middle lobe would be in the area of the breast and the axilla there, so coming and going anterior like that. And then the superior lobe would be above that line that has a 2 on it, so just above there. So those are your lobes. And when we're looking at the lungs, there we go. We've got, we've got a picture on the right side here where you've got the left lung and you've got that fissure going between the superior and inferior lobe coming down on an angle anteriorly there. In that very little picture of just the lung cut out of the body, you can see that that angle continues up and goes superior as you go posterior. So you can see that really, really well there. You can see the fissures a little bit in this picture on the left. You can see that line of the fissure on the left going up like that. This picture is also great for looking at the right, but we're going to cover that next. So for the right lung fissures, instead of rib 5 and 6, we're going to look at contacting rib 4 and 5. So if you count down there, you've got 1, 2, 3, 4 in that yellow zone. So if we are a little more anterior and we have our superior hand when they're lying on their side on that rib 4, a little bit anterior, and then our inferior hand just below that, we should again be able to either have them breathe so we can get a sense of that fissure, and we can apply a little bit of pressure and shear to try and feel for that fissure as well. And so the other fissure is going to be a little more posterior and at more of an angle. And so you're going to move your top hand a little bit more posterior, and you're going to be actually on rib 5 with this one, and then rib 6 for separating the inferior lobe from the middle lobe. So we've got that is called the oblique fissure, and then the other one is called the horizontal fissure. So again, these are just areas we will work with this hands-on in the class. And so don't worry about it too much, but it's good to just start thinking about these things, especially when you're palpating. You might actually find you're really drawn into a fissure. These fissures also, there's an aspect to, this is the right lung, actually the cut away and out of the body. I was going to start talking about the inferior surface, but we'll get to that. So you can see that, again, the inferior lobe actually goes quite superior when you look at it on this picture. When you consider the lung posteriorly, and then the superior lobe, of course, is clearly superior, and then that middle lobe comes in and it actually, there's the bulk of it's quite medial, so, and actually the inferior lobe comes quite medial. They all come quite medial, but they just have a bit of a different pattern as to how that happens. But you can see that inferior lobe wraps around anteriorly just a little bit. And so that's why you can see it just a little bit in some of the topographical pictures looking at the lungs from the anterior. So we're going to talk a little bit about the bronchial tubes. Actually, let me go back here. So I want you to just take a quick look here. You can see that fissure between the middle lobe and the inferior lobe, and how that is actually on the undersurface of the lung there as well. And then if we look at these ones here, you can see that the undersurface of the lung, that inferior lobe meets the inferior lobe meets the superior lobe on the left, but quite anterior. So it's, the fissure will be in a bit of a different spot with that one. And then, of course, you have to take in consideration that the lung lobe is more affected by having the heart there in C2 than the right. There we go. So now let's talk about bronchial tubes. So bronchial tubes are quite deep. If you look at this picture, so this is looking at the thorax laterally. Of course, we've cut away some of the rib cage, also cut away some of the contents. We can see the aorta, we can see the heart there, some of the fascial layer around the heart is actually cut away from these vessels from where the hilum would be, etc. You can see some of that thoracic fascia cut away. You can see the sympathetic chain coming down around the vertebra there. So this is actually really kind of a neat picture. You can see that endothoracic fascia up near the pleural dome as you come into the thoracic outlet superiorly there. So it's kind of fun. But when we're looking at the bronchial tubes, you can see that, oh, gee, these things are really quite deep. They're 50% deep. And if we were to palpate anteriorly, you can see that they're really at that like intercostal space level of rib 2 and 3. For some reason, my whole life thought they were much lower than that, but they're really not that low. So just something to consider. So the one thing about their motility is that they just have a nice superior and inferior roll. So you can actually get on them and feel them. And actually, considering how deep they are, they're usually pretty easy to find and feel once you know how to where to put your hands to assess for that. So again, thinking about the fact that you've got that interpleural ligament and that connection through the hilum, that way the tension in that area there, if it's really loaded with tension, is really going to affect how well those bronchial tubes roll. And then we're going to discuss some of the other tissues all of that actually connects to. But then too, now we can see we got a nice diaphragmatic dome at the bottom of this picture. So here we go. Here's the inferior surface of the lungs. Just again, probably should change the order of the slides. It's important to remember that the fissures continue into that inferior surface and they're in different places on the right and the left. So the right, that is going to be a little bit deeper, whereas on the left, the fissure is actually quite anterior when you're looking at the undersurface of the lungs. And always remember that these fissures, and if there's issues with the fissures, it can really contribute to sticky spots in the diaphragm. Like if you're assessing the diaphragm and you're finding there's an area that's really stuck and you feel like that tension is coming from superior, make sure you think about the fissures as well as the pericardial attachments as well. So angles of the bronchial tubes. So here you can see that the bronchial tubes, of course, bronchial tubes descend into the lungs and they have little branches coming off of them. The reason why the angles are important is that it is thought that since pneumonia is more common on the right side, and it'll be interesting, you should start surveying people in your practice and you'll probably hear that they more commonly have had a history of pneumonia in the right lung. This is often due to that angle of the bronchial tube. It just allows things to drain into it easier than the left. It's like if something's coming down that pipe or just not able to get out, it's going to slip down into that right bronchial tube much easier than it will the left just because of that angle. So just something to be mindful of. And so, yeah, so you've got those bronchial tubes. They're going to have a nice little roll like that. And they're going to be found between the second and third intercostal space there. Innervation. So of course, phrenic nerve is an incredibly important nerve when it comes to the pleura and the lungs. Of course, we remember from school, it's a mixed nerve of motor and sensory fibers, and it's from the cervical spine, C3 to 5. It's of course sensory to the thymus, so that's the immune organ just underneath the sternum. It innervates pericardium, pleura, diaphragm, Glissen's capsule, you remember that from the liver, suprarenal glands, and the upper peritoneum. So these are all of the structures that the phrenic nerve goes to. Um, I introduced this idea mainly because, if you're having a lot of tension at the diaphragm, you may want to consider, what kind of load is that phrenic nerve under? Is it irritated, squished, unhappy, etc.? So it's a very sensitive nerve. When we work with it, if you do decide to go down that rabbit hole with working with the phrenic nerve, you have to be really gentle, really, really careful. Overstimulating it can actually cause diaphragmatic spasm, which is actually not a very comfortable thing. So as you can see from the superior picture, the phrenic nerve goes behind the clavicle, and it is just in front of the anterior scalene muscle. And so it's going to be, very close to that subclavian artery. Vagus nerve is going to be a little bit more medial to it. So you're going to probably find a string along the anterior scalene. So if we come along and just palpate along, there's like a little dip, and you're going to find it just in behind the clavicle there, just in front of the anterior scalene muscle. So I'm just going to move around yeah, right there's the anterior aspect of my anterior scalene. So I know it's going to be just right there. And so do I feel the subclavian pulse? Yeah, I do. So I know I'm in the right area. So I don't want to poke too hard. So be careful with that. But then too, we might find another string in the abdomen at the same side. And so so you're just going just below the rib cage. And sometimes what I like to do is just put a little gentle traction until I feel something that connects. There we go. So you can work with that and just try to create a little bit more space between the two of them. You can put just a light load, 10, 15 grams of pressure there, just a light load, and then work with just creating a little bit of length and space to work with the phrenic nerve. So just be careful not to put a lot of pressure there, but if we have time for it, we're going to go over that one because it can really actually have a really nice impact on the diaphragm. We're going to skip this slide for now because we will do all that work in class, and same with the adjusting. So one of the things I do want to cover is this concept of, so we have a deep cervical fascia. In some textbooks, it's called the deep vertebral fascia, or prevertebral fascia, sorry. And it's a fascia that pretty much divides the anterior and posterior compartments of musculature of the musculoskeletal system there. But it's also a fascia where you have the carotid artery running in the carotid sheath along with vagus nerve, cranial nerve 9, etc. And so it's a really, really important fascia there. But that fascia then comes down and connects with our endothoracic fascia. Again, coming back to the fact that we call things different names, but they're not actually different. It's just continuous, and the name is really just telling you what zone we're talking about it in. And then from there, it will actually come into the endothoracic fascia, be part of that suspensory ligament of the pleural dome, and then go down to the bronchial tubes, envelop the bronchial tubes, and then actually then go down to the diaphragm. So coming back to that lung, that lung ligament between the two, the interpleural lung ligament, all of that is actually one continuous tissue. So, some anatomists think this. From doing dissection, where we actually dissect it in a way to actually look at this and hold some of these structures, like moving the neck while you're holding the heart or working with the diaphragm. It's really interesting how clearly you can see these tissues translate that motion all the way through in a fresh cadaver. So it's, I don't just think this, I really feel like dissection has proven this concept to be very true to me. So when it comes to lung health, one of the things that I always love to do is have a food prescription. The more healthy food we can get in people, the better. Things that the lungs love and benefit from are things like pears, celery, bone broth, and of course, like all the usual stuff is good for them as well. There is an herb called lobelia, and it is really known to be an amazing herb for lung issues. And so, in its alkaloid form, it is known to be an expectorant, a diaphoretic, and a bronchodilator. It might actually trigger the release of epinephrine, relax smooth muscles, and help remove toxins. Actually, under 5 and most homeopathic formulas for the lung will contain homeopathic lobelia. And so Unda 5 is one of the Undas that I use for drainage. I use this a lot more. We've been having a lot more forest fire issues in my neck of the woods over the years, and this is something that I really try to stock up on for that time because people who are just struggling with their lungs a little more, this is really, really helpful for them. And also, I have them continue doing it for a few months after the forest fire smoke has actually calmed down. So Unda 312 is known to be good for helping the throat drain. Unda 27 for the nose and throat as well. Unda 710 for dealing with like those deep sinus infections, so infections that are in cavities. Unda 19 more for tobacco intoxication and cancer in the lungs when you want to clear that out. This can be really useful too when somebody quits smoking. You can combine Unda 5 and Unda 19 to really help them clear stuff out. If they're really struggling with their throat, you can add 312 again. So Unda 24 is considered more of a nervous system remedy. It calms the nervous system, helps the body get a little more into parasympathetic as well. So when somebody has a nervous cough, this might be a really useful one. Unda 32 for when somebody's having having a lot of coughing fits and is really croupy and or needing to actually recover from croup. Sometimes we have coughs that are croup-like, they're not actually croup, etc. So that's another one that can be really, really useful for that. At the end of the day, we've gone through a lot of details, and that can be really, really helpful. But in practice, what we really want to do is zoom out and look at the patterns that we're dealing with. We want to understand the logic of the underlying physiology, and that really helps us ascertain where somebody is at clinically. I'm not here to tell you get overthinky about this, but sometimes there's a time and a place to have some other tools when somebody's coming in with something that they're struggling with. And we always know that the body doesn't make mistakes. It's doing things for a reason. And that's really a central tenet to chiropractic philosophy as well. It's just a vitalistic principle that we want to know why the body's doing this and restore the physiology so that it can return to normal physiology. And I think what's really cool is sometimes people buy detoxification. There's a lot of fads out there with detoxification. They'll buy products off the shelf, and sometimes I've actually seen them do more harm than good. People have bought something that's supposed to help them detox their kidneys and livers, and you're like, actually, your kidneys are not happy about this. And so it's really nice to have that knowledge from my hands. I don't necessarily have to have any sort of fancy technological test or anything. My hands just know. And so it's important. It's an important thing to understand, especially too, because you might have people coming in who are working with other practitioners. And I think it's so great to have a team, but it's also great when you can communicate with those other practitioners and you have some sort of understanding of what they're up to and then can correlate that to what's under your hands. I think the reason I got interested in all of this is because that's what I was seeing. I would see certain remedies or certain strategies actually change what I was feeling under my hands. And I needed to understand that a little bit more. And so it's been really lovely to have tools that I could actually then feel like I had an ability to assess and then actually know where the system was in a process. And then also know when I felt like the system actually arrived to a better state of health. And so that can be really, really useful information. I feel like the one thing about tone too is that I started out creating this course, and I kind of wondered, well, can I actually do all these things that I'm having you do as you engage in our hands-on workshop? And I was a little bit surprised that when I taught it, that I could actually do all those things. I wasn't totally sure. I thought I was asking a lot of the group, and all of us could do it. So that was the cool thing. But then really I realized that when you are actually gleaning information from tone, it is actually a quantum source of information. It's diverse. It's not just like one thing. It's not binary, like ones and zeros. It's a very diverse and quantum type of information to work with, and that we can actually have something that has complex information in there, but get themes from it. Is this theme more emotional? Is this theme more a type of toxin? Where is the system at with all of this in terms of processing it? Has it gone far enough that it's in the cell and accumulating in the cell and degenerating? Is it something that's just more struggling in the extracellular compartment? And so, but this applies to absolutely any questions that you ask. And it just made me really realize there's a wealth of information in tone. It's not just helping you differentiate one pattern from another when you're trying to track something out. It's really something that is like just, you can stop and listen and get all the information you need to work with. And so sometimes, I feel like I'm moving too fast in practice to actually take much of it in. And I'm not saying that you're probably working similar to me in that way, but sometimes just having that ability to step back and glean a little bit more information can really be something that you can use to communicate with this person's healthcare team, but also with that person under your hands. I find sometimes people really find it encouraging when they feel something. It's not necessarily something that is a significant diagnosis or pathology or anything like that, but just to know that they're not crazy thinking that. So often I feel like my job is making people realize that what they're feeling in their body may not be some sort of significant life-threatening issue. It's bothering them for sure. But it's really nice when what I'm feeling and they're feeling correlates. And sometimes I'm able to bring words, or in some cases, sound effects. And people really appreciate it when it's like it rings true for them. So yeah, so definitely this is the time to step into the quantum nature of tone and all the information you can get from it. And hopefully this gives you actually just an avenue to access that information, whether you use any of this information or not. Just being able to access tone in that way, I think, is just another step in your path to mastery. And we'll see you guys all soon. And I'm just going to stop my share here. Oh, thanks. Sorry, don't know what I'm doing. I can't see my cursor. There we go. There we go.